Recording. There we go. So the first thing that I will say, and I'll say this a handful of times, is in this class we're going to learn a lot about modalities, physical agents, modalities. Um, Today we're going to look at some icing techniques, not really learning it, just kind of previewing it. So ice, heat, DP, a lot of electrical stimulations, massage techniques, traction techniques. So we're going to cover a ton of different material. Um, Always make sure you are safe. So if you have an aversion to cold, we don't have to practice our cold techniques on you. If you have a pacemaker, we don't have to do our electrical stimulation stuff. If there's a chance you could be pregnant, we don't want to do our deep heating, diathermy, ultrasound, or traction techniques. So, protect yourself. You don't have to say, hey, everybody, I think I might be pregnant. We don't have to make a big announcement about it, but you just make sure you are in control of your bodies. And we want to make sure you're safe and comfortable as well. So, so just to make sure that that's the first thing that we say, keep yourself safe. The next thing we will say is we are working on getting back to in-person labs. There's a couple of procedural things that we'll have to do to get there, and the plan wasn't in place fast enough for me to say, let's just do it. So I had to make the decision that I think the best outcome for at least today is to be online, and that's probably something I bet you there's a lot of you that were pretty nervous about that, going online for a little bit. So it will be the best that I can make it, and I think there's going to be a lot of different benefits to it. There's going to be some challenges to it as well, but that's okay. We can handle anything. And just know that the goal is to get back to in person when it's beneficial to your education, and we are working on some plans for that. Um, I just don't have any more details than that. So I will open the floor for any questions before we get into this specific class content. We'll review the syllabus and then we'll start into material. So do we have any questions yet? All right, perfect. Now let's see if I can share some content. All right, is everybody looking at the syllabus?
Yeah.
All right. All right, not bad. All right, so here's our syllabus. I'm sure that I don't want to go over too much details of it because syllabus day is always boring for us, but let's hit some important stuff. As always, email me if you have any questions. Don't leave any nervousness, any ambiguity, any problem be unsaid. I want to make sure we are taking care of each other. So our textbook is there. Was there any troubles getting the textbook? All right. Um, so one thing about dress code, I want to make sure that on lab days that we are going to be having to expose a lot of skin in this class, especially when we get to massage techniques. Um, so make sure your clothing is able to access as much of your body as you're comfortable exposing, because we will be looking at some stuff. So, if we're going to be applying a hot pack to somebody's shoulder next week, we need to examine the skin of the shoulder before we put it on there. So, just make sure that your clothing allows access for that as to the best of your ability. A whole bunch of different I'm sorry, not spinal traction jumped out in front of me. A whole bunch of different modalities we're going to be using. It's going to be a decent amount. It's going to feel like a lot of information, and it will be, but there's a lot of overlap between a lot of the stuff. So the list isn't quite as long as this. Like Vapo Cool and Spray, I'm not sure I'm going to spend so much time with that. But so we have to get at least a 75% on everything, on all practical exams and the midterm and final. Here's our grading breakdown. We're going to have 3 exams, 3 regular exams, 10% apiece, our midterm practical, final practical, a final cumulative written exam, and then any other assignments or quizzes will be this last 10%. Dakota, it looks like you raised your hand.
Yeah. I just wanted to know if you have a copy of the book. I just wanted to make sure it was the right one, because when I searched it, it was like a couple different
Yep.
versions.
So I don't know much the difference of the third edition or second edition, but here is the
Okay.
book that I have. But I bet you if you had the third edition, it wouldn't be all that much different.
Okay, thank you.
Yep, no problem. And then here's our outline for our schedule. Obviously, things can change. I think this is gonna work out pretty good, but just know that if schedules change, it's because it's in the best interest of your education and us as a whole. So this week we're gonna do just introduction stuff, some pain cycle stuff, some pretty important science and important factors to consider. Tissue healing, and then we're going to be going into superficial heat and cold. Although I'm going to hopefully steal some heat and cold to kind of break up some of this stuff here. So I believe that's it. Important dates. The ad drop period ends on the 31st. I have to verify enrollment by then. That's for me, not really for you. And the last day to drop the class and receive the grade of a W instead of a letter grade would be the March 29th. So I guess you guys are supposed to be filling that out and signing in at some point. Now, I did put this on Canvas, but it anytime I try to click on it, it says there's a file error. Did anybody else try that?
You put it on what? I'm sorry, Josh.
I put this on Blackboard. Here, let me see if I can share. Oh, share screen. Let's try. So I did put the syllabus under syllabus, and it's Microsoft Word doc. But whenever I click on it, it says it's not found. Are you guys also having that same problem?
That happened to me, but then I just downloaded it as a PDF. Like I clicked the
Okay,
little
and that
things
worked.
in that slide. That worked.
Okay, all right, all right, good. All right, let's stop sharing. So the next, let me try to pull it up on here. So the first assignment that we have to do is this professional behaviors assignment. So this was brought to my attention somewhere around mid-semester late, probably the last quarter, maybe third of the semester. This was brought to my attention that this is a CCRI PTA department policy that we're supposed to do. So when you guys fill this out, fill it out for fall of 21. We'll do it this first week and count it for last semester. But when it was brought to my attention, I thought like, well, that's something that we just don't have the time to do. I felt like I know I was overloaded with work, and I felt like you guys had the same thing, and I didn't want to add one more thing to the pile. So I said, let's kick it down the road. So you can fill this out and just fill it out for this first column. We'll fill it out towards the end of the semester, and that'll count for this next one as well. But it's all of the other skills that we should be developing as young PTAs, and we'll be able to give some comments and some feedback along the way. So this is something that I have to do as well. So you can email that to me, and I will be able to add my comments, email it back, and then we'll be all right with that. Um, so yeah, do that this week, and we'll cross that off our list of things to do. All right, let's share. Let's get into some of this class. So, physical agents. We're intro to physical agents. We're going to talk about pain and tissue healing as well. The first 3 chapters of the textbook. So, my history with physical agents is, initially in grad school, I thought it was really fun, and I thought it was great, and we could modulate pain, and this will help with this amount of swelling, and this will help with this tissue healing. But then early in my practice, I was looking at the research behind, does this stuff actually work? We think we're affecting somebody's swelling, but is this working better than nothing? And the evidence for most of the modalities that we look at is minimal at best. It's either minimal or it says it doesn't work. So early in my practice, I started coming around to that, like, geez, I'm not sure that these modalities that I'm using are actually doing what I'm intending for them to do. I think they might just be chewing up time. So somewhere after realizing that, I said, I hate modalities. I I'm never going to use it, and I haven't touched a modality, any sort of physical agent, in a long, long time. But I started kind of zooming out on it. So I started getting these patients that would say things like, yeah, but I like tens. Yes, but I like the heat. Yes, but I like this. And I started to kind of come around to the idea that the benefit of the modalities depends entirely on the patient. And the placebo effect of a lot of what we do is an important tool to use and not something that we should just kind of dismiss. So I started trying to listen to my patients more, and trying to listen to what they think is important and if they saw a benefit out of it. And a lot of that stemmed from when I was doing a lot of spinal manipulations. I haven't done a ton of them in the home care setting, but in outpatient, I was doing a lot of them. And when I would have a patient that would be very fearful of a spinal manipulation, guess what? That manipulation isn't going to work for that patient because they're so fearful of it. Um, but then when I'd have a patient come in and say, "Oh, I think that'd be great," well, it doesn't matter at that point if I think it's going to be good or bad. They perceive benefit out of it, and that's ultimately going to help. So, I'm starting to think that in order for me to use a modality now, the patient has to fit the indications that this modality, this physical agent, will benefit them. The patient has to have a mindset that it will benefit them, and then the therapist has to believe in the benefit as well. And I posted a link to this article, and you don't have to read it. It's just there if you have extra time and you want to read it. Basically, the summation of that article is just the importance of that that interaction of the therapist's belief and the patient's mindset. So, um, so pretty interesting stuff to see. So this class, we're going to be talking about a lot of different physical agents and how to best apply it. So we're going to want to make sure that our patient fits the indications. What are the indicate? What does that mean? Indications.
That it's safe for them to have done.
Yes, yes, they fit the criteria that it's safe. And actually, I don't know if safe. I guess that's part of it. Um, But basically, they have this problem set, and this physical agent tries to solve this problem set. Um, so in order for somebody to use pain relief technique like tens, well, I don't want to put tens on somebody who's not complaining of pain. They don't meet the indications of it. I'm just doing it for fun. I think the contraindications, Trish, are more the safety criteria. So contraindications, do not do it. So, like we said earlier, if somebody has a pacemaker, that's going to rule out a lot of our electrical stimulation. If somebody's pregnant, that's going to rule out a lot of our DP, basically anything, but DP and traction type modalities. So, there's a handful of different contraindications for each one that we'll have to be aware of to make sure that we're not doing it. Precautions, take a minute and think, do you really need this or not? Is this important to do today? Maybe you need to gather more evidence. Maybe you need to slow down and think. That's what precaution is. We're going to learn how to document it as best of our ability. And then, so that's all um, hard evidence. That's all yes or no type criteria. The extra things that I want to make sure we give you are more clinician advice. So that's both Tony and my clinical expertise and our experience in saying, hey, when you do this, it's a good idea if you. So little things like how do we put a towel on somebody to protect the ultrasound gel from getting everywhere? So that's something we want to see, and we'll give you some tips on it. But it's not in the book, and it's not going to be an exam question. The other stuff will be exam questions. Um, so we're going to try to make sure that's clear. I know that sometimes is frustrating for you as students when, especially if Tony and I have different opinion on something. Well, we're just trying to give you our expert opinion and our experience and ways to think about things. And it can be frustrating when you're just trying to pass the test, pass the practical. But what we're trying to do is give you our clinical expertise that you get to be well-rounded clinicians in the future. So I know how frustrating that is, and I'm going to try to make sure that um, that stuff is clear where we're going to say you're not going to be tested on, Tony saying you should have used one extra towel or not. Um, so I'm going to try to make sure that's clear. I know that was frustrating sometimes last semester, and we're going to try to get better at that. So general contraindications for physical agents: pregnancy, malignancy, pacemakers, impaired circulation, impaired sensation. So those are the big broad ones that we're going to say, oh, we can't use this for. I will say in physical therapy practice, the top two mechanisms of patient injury, number one is exercise injuries. So somebody's trying to do an exercise and they get some sort of muscle strain because of it, or a sprained ankle when we're doing agility drills, that kind of a thing. So exercise induced injuries. The other one, and I believe it's number one, is injuries from physical agents, and especially burns. And you would think it would be hard to burn somebody, but it's actually pretty easy. Um, so we are going to want to make sure safety is number one, because we don't want any injuries to our patients. It's tough to get their knee feeling better when we give them a burn around their thigh. So we want to make sure we keep our patients safe. Um, so just in broad strokes for these contraindications, pregnancy is going to be a contraindication for almost all of our modalities and a lot of our hands-on techniques as well. One of the reasons for that is kind of a protect yourself scenario. So there's roughly 20% chance of miscarriage in a pregnancy. And on a protect yourself standpoint, we wouldn't want to do an ultrasound to somebody and then that night they have a miscarriage. That's going to theoretically tie it back to us that we damaged that pregnancy. So we don't want that risk at all. And the risk reward ratio just isn't there. Even if there's no evidence that ultrasound does do damage to this fetus developing, it doesn't matter because the risk reward is just not there for us to make that chance. Cancer, so either active cancer or history of cancer. So if there's a history of cancer and we do some of these modalities, we could spark that cancer to grow, either to regrow or to grow faster. Pacemakers, keep controlling the electrical system of the heart. We wouldn't want to use anything that would impair that medical device because guess what? They kind of need it. Impaired circulation is listed here as a contraindication because if there's impaired circulation, once we get a burn or some sort of other injury, it's going to be that much harder um, to heal. Impaired sensation, they're going to let something burn them. We're gonna put a hot pack around somebody's foot and they can't feel that it's getting too hot. Another general safety device is we always want to provide the patient some sort of a bell or a timer to alert us that says, hey, something's wrong. Or if we can, the shut off to the machine. So on a lot of machines, there's shut off, emergency little shut off switches that we just hand to the patient. If this starts feeling uncomfortable, turn this button. And that'll shut off the machine. So those are our general contraindications and some safety stuff. So the next thing we're going to have to do is we're going to have to examine our patient's skin. So whatever we're doing, I don't care if we're putting a hot pack on somebody's low back. Guess what? We should be examining their low back skin to make sure that it has enough integrity to withstand that. So the first thing is sensation. Can they feel? Because if they can't feel, then they're not going to be able to better tell us if something's going wrong. So if they have impaired sensation, again, that's a contraindication that we have to really be aware of. Now, we could go crazy and we could test hot versus cold, sharp versus dull. Those have more to do with the spinal tracts being involved than it does any one thing. Usually, light touch is just enough to have us say, okay, that's good. So touching somebody's on the around the elbow. If we're going to put a hot pack around their elbow, can you feel this? Yes. All right, perfect. Let's move on. But if you see somebody with different spinal cord injuries, there might be some specific stuff. We'll get into some of that a little bit later. And then looking at overall skin condition, the overall integrity, our skin screened C triple T me, color, texture, temperature, turgor, moisture, and edema. So what is the overall integrity? What is that overall color? Do they have appropriate capillary refill? We might be able to test peripheral pulses. Sometimes that'll be indicated to say like, oh, we'll just check this to make sure they do have adequate blood flow. That I don't see very often, but that could be a consideration for it. So overall, when we're assessing the skin, we're asking ourselves about the overall integrity of the skin. Is it smooth, uniform? No one area looks worse than the other, no broken skin, and then it's okay to put our modality on it. So we have a handful of different types: thermal, mechanical, and electromagnetic. Thermal is we're going to be looking to increase or decrease tissue temperature. Mechanical, we're going to be looking to change the forces, increase or decrease, change the pressure within or on the body. And then we have electromagnetic, where we're going to be applying some external energy to the patient. Now, let's see. I heard a ding. Let's see.
That was me, Josh. I was just going to ask you to advance the slides, and you did it right when I raised my hand.
All right. Good. I think. All right. Is that okay to see? When I turn this on into presenter view, I stop seeing the collaborate camera, so I don't really see what you're seeing. So is this an okay view for everybody?
That's good. Before we couldn't see anything but the opening slide.
Oh, really?
Yeah, because we only see what you click.
Oh, but I was clicking the entire way.
Oh. Huh.
Oh,
It's working.
all right. Well, that's good. All right. Does anybody need me to go back to anything? No? All right. All right, where were we? So we have thermal, mechanical, and electromagnetic types of physical agents. So our E-stims, electromagnetic, some other stuff there. Mechanical traction and massage are the biggest ones. And then thermal, hot and cold is what we'll be talking about there. So we can break down our thermal modalities a little bit more. So we have superficial heating. That's going to penetrate less than 2 centimeters. So we have our moist hot pack. We have hydrotherapy with warm water. Moist hot pack is probably the number one there. How if we were in lab, I'd grab the tape measures, and once we get into lab, we'll grab a tape measure. How much distance is 2 centimeters? Is that like a lot, or is that a little? What do you think? Not quite the width of a finger, right? So when we think of our anatomy, when somebody's got low back pain and we put a hot pack on their low back pain, what do you think we're heating up for most people? We're probably just heating up 2 centimeters of adipose tissue, right? So when we choose these superficial heating modalities, like you have to really think like, is this getting to the tissue that I want? If I'm trying to get to somebody's paraspinal musculature, is there too much other tissue for me to reasonably do that? Um, so a consideration for us, we'll dive into definitely later. We have deep heating, which is going to penetrate between 3 and 5 centimeters deep. So again, even then, like not all that deep. And once we get to lab, we'll look at that. Lori, what do you got?
A question on a superficial heating, does position matter? Like if you had the low back pain and you were
Yep.
sitting down, would you, if you were sitting down and you were sitting in a chair and you had a heating pad on your back versus if you were laying on your belly and you were down laying prone and you had it that way, would you want the heating pack against your skin so it penetrated a little deeper, or does position matter?
That's a great question. We will expand on this if next week probably we'll expand on it a little bit more. The short answer is the depth it penetrates isn't going to change by all that much, but the intensity of that heat distribution to that superficial will be more. So if we are laying on top of our heating source, then it's going to be much more intense. We're at greater risk for burning our patient, but the depth it penetrates isn't going to be all that much more.
Okay.
But the intensity will be greater.
Thank you.
Yep. So we have deep heating, so 3 to 5 centimeters deep. Again, not that much. So there are deep heating that we'll look at. Ultrasound, the number one most popular form of deep heating. Diathermy is something we'll look at and practice, although it's not used very much in the United States. Popular in the United Kingdom, I found out. So again, if you want to travel abroad and become a PTA abroad, then you'll have to dust off your diathermy. So if you go to Italy, you'll have to make sure your Canadian crutches fitting is on point, and then if you go to the United Kingdom, you have to make sure your diathermy is on point there. And then we have cooling agents. Cold packs, number one, most common one. Hydrotherapy with cold water. Cryocuff is similar. You guys remember the compression sleeve that Tony and I demonstrated? We didn't have you guys practice it, but we demonstrated it. Similar to that, it's a big sleeve. You put your whole limb in, and then it circulates cold water throughout it. We also have vasocoolant spray that is not popular anywhere in the world except for former Soviet Union countries. They are very popular in the Stan countries, Uzbekistan, Pakistan. So if you want to go to those countries, then you pack your vasocoolant spray. Our mechanical modalities, traction, cervical or lumbar traction, different compression, the Jobs pump that we just talked about, different A strapping we could talk about as well. some water therapy with the turbine, the water blowing directly against the skin, that would then be considered a mechanical and not just a thermal. And then sound, pulse ultrasound would be a mechanical modality. So if we had continuous ultrasound, that's going to be for deep heat. Pulse ultrasound, that's going to be more mechanical. We're not going to get to thermal levels. We'll get to that in, I think, week 4 is when we'd start tackling ultrasound and diathermy. So if you don't understand that yet, that's okay. Don't worry about it. Electromagnetic modalities, we have phototherapy, UV radiation, infrared radiation, some diathermy. And then the electrical currents, we're going to change the polarity of cells, but also change the sensory input. That's the purpose of it. So changing the polarity of cells can be really good for edema control, and changing sensory input is going to be really good for pain control. And we'll talk a lot about pain today. So here's a bunch of our, this is basically the list of things we're going to learn this whole semester. So I hope that's not overwhelming to you. I hope that's a little bit kind of relaxing to say, like, wow, everything we learn is all on one slide. So I hope that relieves some anxiety and not increases it. And if you want to hear something really ironic, I get to teach Trish about massage this year, so that's going to be really fun. So touching on evidence-based practice. So evidence-based practice is integrating the best research that's available with your clinical expertise, the clinician's experience, as well as the patient values. And that's where I think I went wrong. So if we consider that a Venn diagram of those 3 bubbles, best research, patient values, and then the therapist values and experience. I think early in my career, I focused so much on the evidence that I ignored my patient values. Um, and then learning more about my patient values, I'm be able to better integrate the research, patient values, and my expertise with that. So it really is the combination of all 3 that we want to be really good at developing. There's a few things we have to be aware of, though. Now, while there are major gaps in scientific knowledge, it's also a really big problem where we have scientific evidence that we're not using. So when evidence clearly says ultrasound does not help with low back pain, but we see clinicians still using it, that's really frustrating for me as someone who I try to balance all of those things together. And I don't think we advance our profession by using things that we know don't work. Um, so there could be at a time and a place. If the patient says, "I definitely want this," then maybe we do it for a short time to get our patient on board with us. But it's not an effective therapy technique, and we have to really consider, like, if we bill our insurances for these treatments that we know don't work, is that fraud? Is that something that's ethical for us to do? So the arguments for using evidence-based practice, one, it's for the benefit of the patient. Not using something we know that doesn't work is only wasting our patients' time, and it's preventing them from getting to the solution and the treatments that could benefit them. Decrease using evidence-based practice increases the credibility of the profession, increases the efficacy, the truthiness, and the value of our treatment. And then it's more adaptable to changing reimbursement policies. I can't tell you how many times I have an insurance company call me up and say, "Yeah, but where's the evidence for that?" And if I can provide it to them, then it's fine. They're off my back. Um, some barriers to using evidence-based practice. Well, limited time. I get 3 journals a month, and they're chock full of articles, and each article takes a really long time to read. So it's really hard to stay up with it, the time to read evidence. Access to the best evidence is really tough. As students, you guys have way more access than once you become clinicians. So that's really frustrating, and that's something that when you're out in the field, your clinical instructors say, "Oh, good, I have a student, I can access all this research." Um, lack of knowledge on how to incorporate evidence-based practice, inability to integrate patient preferences with evidence-based practice. And again, that was something that early in my career, I had a really hard time doing, integrating my patient preferences with the best evidence. And I value my patients' considerations more and more. Um, and then lack of adherence to clinical practice guidelines. So if the clinical practice guidelines for low back pain says exercise is better than modalities, yet we keep using modalities, uh, well, that's not adhering to those clinical practice guidelines. So there are 5 steps to get to implement evidence-based practice. I don't want to go into that too much today. You'll get into that a little bit in other courses, so I didn't want to spend too much time for it. But to really drive the point home, you have to factor best evidence, your patient preferences, what are the goals of the treatment, the depth of the target tissue is something that I think we really underestimate. What is the patient tolerance and what is the ease of application? And then also, what is the stage of healing? So there's a lot that goes into our clinical decision making. And the old motto of the Physical Therapy Association was science of healing, art of caring. And that's really good way to sum up what we're trying to do. Use the best science we possibly can, but apply it into a caring way for our patients that might have different ideas than us that we can easily better integrate the two. So we have a couple of different uses for physical agents. So we could increase muscle strength. So some different e-stims, neuromuscular electrical stimulation and Russian are 2 examples of that. We could decrease muscle spasm. That could be very important for us. So trigger point massage and biofeedback are 2 great examples of that. Accelerate tissue healing. So if we're changing the cell permeability to allow nutrients to better flow back and forth, that's going to improve tissue healing. So ultrasound and e-stim may do that. Decrease edema, cold and light massage. Uh, not light as in UV light or anything like that. I'm talking superficial massage. Or we could decrease pain with it in TENS and IFC. And there's most of our modalities are going to modulate pain, and we'll look at how that is in just a little bit. Um, so, do we have any questions right now? That's a kind of an overview of the course. Um, we'll get into some pain next. Pain is we're going to dive deep into pain. But here's what I want to do. I want to make sure that this is a really important topic. So I'm feeling like we should take about a 5-minute break to make sure that we're ready for this. Okay. So, refill your coffees, use the restroom. Let's come back in um, about 5 minutes. So 9:25 is what I'll say. I'll start up again. Okay. All right. 5 minutes. All right, I'll wait just one more minute to make sure everybody's back at their computers. All right, I added a poll. So once I get a bunch of answers, then I'll make sure that we're all back. That's pretty cool. I didn't know I could do that. You guys are 16 of you are liars. That's good. Now I know a little bit more about you. All right, good. One of you is a truth teller. Good for you. All right, so let's get into pain. Now that I will say, I think this is the most important thing that we can really start taking home from this. It does get complicated. So interrupt, ask questions. If you, I like the hand raising button. That's pretty good. But if you just open up your mic and just start talking, that works too. So don't feel like you have to stay quiet because this will get complicated. So, pain is an unpleasant sensory and emotional experience associated with actual or potential damage. It can be a good thing. It actually is a good thing because it indicates that something's wrong and the pain is stopping us from doing something to further damage our tissues. So, if we step on a nail, that pain is going to tell us to stop stepping on the nail. If we put our hand on our stove thinking it's off, but we start burning our hands, that pain is telling us, hey, stop burning your hand, and hopefully we're preventing the burn from progressing. So it can be a very good thing. So pain is influenced by a lot of different factors, and we've discussed this briefly in our class last year. I know I've mentioned it. So pain can be influenced by the attention that we give to it, our overall levels of anxieties, degrees of suggestibility. The degree of suggestibility, a perfect example is with kids and taking out splinters. So once they see the tweezers, it's like, oh my God, like, the suggestion that it's going to hurt is just too much. Level of arousal, degree of fatigue, previous emotional and psychological experience with pain, and then also cultural norms. And we could go on and on and on how pain is influenced by many different factors. Um, I've always said the cold, rainy, cloudy days, everybody's pain is worse. When it's 78 degrees and the sun is shining and the birds are chirping, everybody's pain is better. So that definitely happens. Um, if we get into an argument with our kids or spouse or brothers or cousins, whoever we get into fights with, all of a sudden my knee pain jumps from a 2 to a 4 because of that experience. So yeah, pain is influenced by a whole ton of factors, and it's really important us to understand that it's a really broad spectrum thing, and that's actually why we use pain as a subjective measure and not an objective measure. Because if it was objective, I could clearly measure it. Subjective, there's so many factors to it that it's not as reliable data. So, what can pain cause? Creates a number of adverse events. First, muscle guarding. That muscle guarding can lead, prolonged muscle guarding can lead to weakness and decreased range of motion. It can also cause fatigue, insomnia, increased irritability, anxiety, depression, decreased appetite, impaired sexual dysfunction, and emotional distress. And I think it's really important to understand this because in our first interactions with a new patient, they might be jerks. They just might be the kind of people we don't want to be around. But it's really important to understand how pain can change your personality, can really affect who you are as a person. I don't know if anybody's ever experienced this. I bet you we've all experienced this. When we've got the flu or we got COVID, and how we're overreacting to these little things that we shouldn't be. So all of a sudden, everything in the world is annoying to us, and that's just with being sick for a few days or a few weeks. So I bet you we've all experienced that personality change, discomfort causing personality change, and pain is the same. So we have a few pain terms that we're going to use. So nociceptor is your pain receptor. We have a bunch of different types of receptors in our body. Some detect sharp versus dull, some detect thermal, and nociceptors detect pain embedded within the skin, and then they transfer their messages to the nerve that it needs to go up to the spinal cord and then brain. Anesthesia is absence of pain without loss of consciousness, and anesthesia is loss of sensation. So acute pain can be from the result of infection, injury, or some sort of internal disease. Pretty predictable characteristics, easily localized. Where does it hurt? It hurts there, and pretty easy to diagnose and treat. And it's pretty easy to relieve pain from our patients. And I'll say easy with a big grain of salt, easy enough. Sometimes it's still very hard, and but it's easy enough. The far more complicated is chronic. So chronic pain is defined as pain that lasts longer than 3 months. I don't like the font on this. Let's try to make this a little bit bigger. Uh, Chronic pain is defined as pain that lasts longer than 3 months. Uh, Not to be confused with some sort of inflammation cycles. Edema, having edema last longer than 1 month is the chronic edema definition. So just understand that acute and chronic can mean different lengths of time. It's not all universal. So in the pain world, pain lasting longer than 3 months is considered chronic. Cause is uncertain or not correctable, and medical treatments have been ineffective to alleviate this pain. For someone who has pain for that amount of time, there's great consequences for the psychological well being of the patient as well as their families. This ripples out greatly into the rest of their world for all those reasons that we've just talked about. So, mechanisms of chronic pain are poorly understood, but could include some sort of mechanical process. So, if we had stenosis is an easy one to think about. Carpal tunnel is another one that's probably pretty common, something you guys might be familiar with. Could be chemical. So, what happens is there's a positive feedback loop causing pain, and we'll look at that later. Don't get too confused on that. Could be some sort of regeneration, so nerve endings regenerating after trauma. Reflexive, so chronic muscle guarding would be a good one. So the muscle guarding has been happening for such a long time that it's not letting up, and that's the cause of that chronic pain. And then an inhibitory failure. So what should happen with pain is you experience pain, and the body releases these endogenous opiates. So the cell body self makes its own opiates, um, and the lack of the ability to do that will kind of feed forward this pain cycle. Or it could be the lack of the dorsal horn limiting the transmission of pain. So a couple examples of that is thalamic pain syndrome and multiple sclerosis. So endogenous opiates are something we're going to talk about a lot today, and probably a lot this whole semester, and something that's really important for us to consider. Endogenous opiates are is created by the body, and it's meant to stimulate the blocking of pain. So how do we generate these opiates? Well, pain causes them to be released, but also intense exercise, laughter, relaxation, meditation, acupuncture, and some electrical stimulation can all stimulate the release of these opiates. So when we talked with our patients with chronic pain, um, we should include some of these techniques to help them. So when was the last time you watched a funny movie? When was the last time you try to do some sort of relaxing technique, breathing techniques, meditation. All of those can be really, really helpful for our patient to simulate these opiates and to modulate their pain. So some examples of them, if you want to know the deep science of it, beta endorphins, serotonin, dynophins, dopamine, and enkephalines are the ones, the categories that we would talk about. So one thing I want to impress is the chronic pain. The treatment should include multiple healthcare workers and really a team of healthcare workers. It's not. It shouldn't just be on us, especially psychologists. Now, just because somebody has pain for 3 months doesn't mean I'd say, oh, immediately go see a psychologist. But I do think that for the if we think of chronic in a greater term, I've had back pain for 10 years, or the kind of person that they almost identify with their pain. I am someone who has low back pain. You know, woe is me, feel bad for me. You'll definitely come across those people. A book that's fascinating about the psychological trauma causing pain is a book called, or I shouldn't say causing pain, it should say causing physical impairments, because it's not always about pain in this book. The Body Never Lies by Alice Miller. Really fascinating. She's got 8 or so different people, more women than men in the book, on that experience some sort of psychological trauma, and then how that helped create different diseases along the way, not just physical pain. So pretty interesting. When you guys get an extra 10 hours or so to in your lives to read a novel, then go ahead and crack that one open. Another type of pain that we want to talk about is referred pain. So pain that's felt in a site that's different from the origin. Uh, so the spinal segment tissue causing referred pain down the appropriate dermatome. We haven't talked about dermatomes, right?
No.
All right, let's see. Me create a new share. So here's a map of dermatomes. So all it means is that as the nerve exit the spine, that area of sensation is going to be all in the same dermatome. So as our nerve exits C7 neuroforamen, this strip of skin is all controlled by C7. So if I sprained my finger really badly here, it's going to send signals up through this dermatome up to C7, and I could experience pain anywhere in this dermatome just because of the way that nerve runs. That's the really broad overview of that. Does that make sense? Good enough. So that's easy to see how pain can be referred anywhere along that dermatome strip. We'll make that a little bit more complicated in just a little bit too. So referred pain. So again, in that example, I didn't just because I hit the hammer on my finger, my elbow could hurt in that strip just because of the way the dermatome is right there. Um, it's also could be easy example is an issue with an organ that caused pain to be perceived in the musculoskeletal area. So if a man is having a heart attack, experiencing shoulder and jaw pain is a really common example of that. Or the other common example is if you're having a kidney problem, kidney infection, kidney stone, low back pain is an easy one. So, you know, if we have somebody and we say, geez, it looks like you're sweating a bunch, you're complaining of jaw pain, you're kind of clutching your chest a little bit, let me put some ice on that shoulder for you. Well, that's not going to fix that's not the origin of the problem. That's just a referred pain. Um, Same thing, and we actually see people with low back pain a lot because of kidney infections or kidney stones or even some sort of kidney cancer. That low back pain is the major complaint that they have, but nothing we do is going to solve their problem. We've got to get to the organ of the issue. Just like if in that finger smashing example, you know, smash my hammer on my finger and I'm experiencing pain all the way up to my elbow for it. Well, you don't need to do anything to my elbow. That's not going to solve my pain at all. Go fix the finger. So I want to just talk broadly about the pathway of pain of all sensation. So first, all sensation goes to a receptor that's embedded in the skin, and we talked about there's a lot of different receptors. Some messages receive messages about pressure, some light touch, some hot versus cold, some sharp versus dull. So there's a lot of different receptors of all of our different sensations that we could be experiencing. So the receptors receive that special signal and then it transmits that message to a nerve. The nerve has to go up to the spinal cord through the dorsal horn. So that's the dorsal horn nerve root. And then it goes to the spinal cord. Now, you guys know how different lobes of the brain do different things, right? So, you know, the frontal lobe, personality, judgment, occipital, vision. So each lobe of the brain has its own role to play. The spinal cord is the exact same, except we don't call them lobes, we call them tracts. And you know, the spinal cord and all nerves are just a highway of messages. So we have ascending tracts, so that signal's going up to the brain, and then we have descending tracts, that signal's coming from the brain to wherever it needs to go. So the different lobes, so there are of the spinal cord are different tracts, and we have different tracks that control pain, different tracks that control temperature, different tracks that control proprioception. They all have their own role to play, just like different areas of the brain have their own role to play. That's not too complicated, right? So then that message you climbs the spinal cord with the ascending spinal tract, and then it goes into the brain. The brain sorts out the information, figures out what to do, and then the brain sends the signal down the spinal cord, down the descending spinal tract of wherever it needs to go. And then there's some sort of reaction, example of muscle contraction. So if I smash my hand with that hammer again, I have a pressure input, I have a pain input that all goes up to my all into the nerve up through my arm. In this example, it would be the median nerve, I believe. Uh, and then we would go up to the spinal cord level, up into the into the specific tract, then up to the brain. The brain sends a descending message to say, hey, don't swing that hammer one more time. You missed the nail. You hit yourself. So that's the reaction. Is that overall, does that make sense? Good enough? Have I lost anybody yet?
Yes.
Okay. All right. Um, so Trish, do you use different temperatures of um like massage gels and oils and things like that?
Sometimes there's products that for pain. One you probably have heard of BioFreeze.
Yep,
Um,
I'm not talking about, just for pain. I'm just talking in general. Do you have some things you say like, "Oh, I'm going to do the heated thing today," or, heated stone or whatever, like,
yeah, depending on where I'm working,
yeah.
so yeah, there are different
All
things
right.
that you can do, hot stones, that kind of thing. Yeah.
All right, so let's use hot stones as our example.
Okay.
So you're about to put the hot stones on somebody. You go grab them off the shelf or wherever they live, and you realize like, "Ooh, these aren't hot enough. These are cold still." So what happened to make that happen? So you touch the stone. Here's my stone. I
Yep.
touch it and I say, "This isn't the temperature that I wanted. This is supposed to be warm. It's not." What happened to make me do that? The sensory receptors in my hand that determine hot versus cold, they grabbed the signal from the stone. It went into my receptors of the skin. That went into my nerve to transmit the signal to my spinal cord. Spinal cord goes up to the brain and the brain processes it, and you get to say, "This isn't hot. This is not hot enough for what I want." And then we have to have a reaction. So that's the cognitive processing. Then the reaction is, let me go put this in the warmer, hot water, whatever, however you heat them up again, right? There's a decision to make, and then you have that action. Does that make sense?
It does make sense. I would
Yeah.
say just for scenario, typically they're too hot, and I have to let them
So
cool down.
I was
But
going to go. I
same
was going to go
example.
there next. I
Yeah.
was going to go there next. That's the exact same example, except now we're also adding a pain signal to it. So if
Mhm.
it's too hot, it might be so hot where you pick it up and go, ah, like you have this. So let's add that to it. So what happens there? So we have you touch something too hot, that rock you thought was going to be warm, instead it's scalding hot.
Mhm.
Now Trish is experiencing a painful scenario. That painful scenario is taking the same path. It's going into the nerve, then into the spinal cord, then up to the brain. And the brain, instead of making a decision saying, "Oh, let's go gently put this in a warmer," the brain says, "Holy cow, this is damage. Let's stop the damage." And it's going to have this immediate reaction to make you drop the rock. Does that
Yeah.
make sense?
Yes.
That's all we're talking about.
Okay.
Does that help clear it up a little bit?
Sure. Good. I
Okay.
think
And
it's a
is
good example.
anybody else confused by that? Because we're going to add some layers to this that is going to be a little bit more complicated. But does everybody understand the fundamental receptor to nerve to spine to dorsal horn in the spinal cord to up the spinal cord to the brain and then down to have some sort of reaction, whatever the body might be? Because that's important. Everybody understand that sequence so far? All right. So, am I showing the PowerPoint? Yeah. Okay. All right. So this reaction happens a ton of times, not just with pain, although that's what we're going to be talking about a lot today. So the pain cycle is exactly everything we just talked about. So there can be that withdrawal, that dropping the rock mechanism. But what happens for us that causes the more prolonged problem is they muscle guarding. So I know I've been in the area. Anybody ever like hurt their arm? What happens when we hurt our arm? I see a lot of cameras on. So what happens when we, if we fall, we, land on our elbow? What do we do? I think Cassandra's got it. What are you doing?
You grab your arm
Yeah,
right when you fell.
you're pulling it in close. You might support it with the other one. So that's muscle guarding. Okay. So muscle guarding is a protective mechanism. So our muscles are our armor. It's trying to protect that injured site from getting hurt even more. The problem is with a lot of our patient is that we never stop muscle guarding. And then that muscle guarding leads to more dysfunction. So I bet everybody's experienced this when anybody ever and Justin's too young, so he hasn't experienced this. But some of us in the room can remember when we wake up in the morning and we quote unquote slept the wrong way, right? Our pillow was just kind of folded the wrong way, and you have that neck pain. You guys ever have that? So what happens after that? So then the muscles contract as that protective mechanism. And then the neck pain isn't really the problem 3 days later. That's resolved. But the muscle guarding of, wow, it hurts here and then there, that muscle guarding then becomes a problem. And that's going to cause additional dysfunction. And Trish, you must see this all the time. I mean, that cycle you must see all the time, right?
Yes, a lot of times where clients are feeling the pain isn't really where it's coming from. And I'll try to talk to them and they're like, I slept funny like 5 days ago. Oh, okay. Or, whatever the
Right.
situation is. Yeah,
Right.
absolutely.
So I bet you we've all experienced this in some way. And Justin, I know I minimize your age, but I know you felt this, and you and I have talked about some of your bicep pain, how this is the exact path, right? You had some sort of injury, then the muscle guarding never lets up, and then that's now the new problem. We're adding to the problem list instead of taking it away. So yeah, we've all felt this in some way, that muscle guarding to dysfunction. So let's explore it just a little bit more. So um, broadly speaking, we get physical injuries from three sources: abnormal load, abnormal structure, or cumulative microtrauma. So abnormal load, I get hit by a car, I jump and my I'm playing basketball and I land when I come from jumping and I land on somebody's foot and I sprain my ankle. That's that abnormal load, right? So my ankle wasn't meant to withstand that load in that direction. Abnormal structure can be from a lot of different things: osteoarthritis, weakness. So weakness would probably relate to the abnormal load a little bit more, but there's a little bit of overlap there. Um, so the most common one that I see that impacts me is everybody knows what their acromion is in their shoulder, right? So there are acromions that are flat that have a lot of subacromial space, and there are some that are hooked. Now, the hooked acromions become a really big problem for somebody who enjoys overhead sports, throwing, rock climbing, swimming. So that is the abnormal structure. So we're never going to have you swim 6 days a week comfortably because you have this abnormal structure here. And then cumulative microtrauma is something that we're all experiencing now, sitting in our desks that aren't meant to be desks, sitting in our chairs that aren't meant to be sit on for hours, however many hours today. That abnormal posture is going to accumulate over time and cause some dysfunction. So those are the three broad ways that we can create a musculoskeletal injury, and our treatment should be aimed at that. So those injuries are going to create pain. The pain is going to create muscle guarding. The muscle guarding is going to create more dysfunction. That more dysfunction is going to create more pain. That more pain is going to create more muscle guarding. That more muscle guarding is going to create more dysfunction. That more dysfunction is going to create more pain. And it's this vicious, we call this a feed forward cycle or a positive feedback loop. Um, so where the problems pile on top of one another. So it's our job as PTs and PTAs is to interrupt this pain cycle. Have I lost anybody on the pain cycle? So this is the same thing we were just talking about with the hot rocks. So hot rocks pick it up. So that would be an abnormal load, right? That's thermal. But if the rock was 700 pounds and I tried to lift it up, then that would be the abnormal load as well. So abnormal load, the burn, so too high of a temperature, that creates our initial pain. I let go of the rock and I might guard right? I might, shake it a bunch and then guard it. Now I'm not using it for a while. Now for the next week, I'm afraid to use my hand. Well, that muscle guarding is now going to cause impairments at my biceps, maybe my shoulder internal rotators. So then that is creating more discomfort. Now I have pain in my biceps and my shoulder. That's going to create a new source of pain, which is going to create new muscle guarding, which can create a new source of pain. So that's the positive feedback loop that we're talking about. So I want to really dive into this pain cycle and everything that we just talked about here. So we're going to add more and more layers to this. So pain perception starts at specialized receptors called nociceptors. There are 3 different types of them: high threshold mechanical receptors, mechanical thermal, and polymodal nociceptor. So high threshold mechanical receptors, strong mechanical stimulation is needed. The sensation is pricking. It is well localized sensation. It's well localized um, receptor, and it's very fast in its signaling of messages. The nerve fiber, so we know how receptors go into nerves, and the nerves go into the dorsal horn of the spinal cord and then up to the spinal cord. So to break it down even more, there are different nerve fibers that can be stimulated. The type of nerve fiber here is A delta fiber, and we're going to recap this in a few different ways. Mechanical thermal is going to also add that noxious heat, so that's that hot rock. So the hot rock, we're looking at our mechanical thermal receptors. When I was just smashing my hand with my hammer, that was the high threshold mechanical receptor. Same nerve fibers that it goes to, so A delta nerve fibers, fast, and again, these are well localized sensation as well. The polymodal is also looks at irritant chemicals. The sensation is going to be dull, aching, burning. These are a little bit slower of a nerve fibers, and they are C fibers. We're going to add more to this in just a little bit. Don't get too hung up on that yet. So we started saying, well, there's a bunch of different receptors controlling different things. And now we want to talk about pain. So the type of pain receptors are called nociceptors. And then we could say, well, even within nociceptors, there are 3 different subtypes of it. So this is getting complicated pretty quick. But that's okay. We're going to keep building on this. We're going to keep going back and forth today on this. And really all semester long, we're going to keep referring to this. So if you're not quite there yet, that's okay. Broadly speaking, I think we're all on the same page. Receptor feels a stimulus, sends it to a nerve. Nerve goes to the dorsal horn of the spinal cord, then into the spinal cord on a specific tract, up to the brain to sort out what's happening, and then down from the brain to have some sort of reaction, whatever the wise reaction would be at the time. Broadly speaking, that's what we need to know. We're just adding some layers of complexity because when we add our modalities, it's at this micro level that we are attacking the pain for. So the pain comes from nociceptors and it goes to a nerve. There are 2 different types of nerve fibers that these pain signals can travel on: A delta and C fibers. A delta are smaller in diameter, but they are myelinated, so they are faster. Well localized, it hurts here, right? So they're very, so that helps us. C fibers are small in diameter, but they are unmyelinated. That means they are slower in their transmission of signals. They also have longer lasting pain. So burning pain, dull, poorly localized. So nerve fibers go to the dorsal horn of the spinal,
Hey,
dorsal
Josh.
horn nerve root. Yep.
Sorry to interrupt you. You said on the A delta fibers, they're small in diameter and myelinated, and
Yep.
the C fibers are small and I cannot pronounce
Yes.
that word. Thank
Yep.
you.
Yep. Unmyelinated. Yep.
Okay. Thank you.
Yep. All right. So let's add another step. So receptor, nociceptors, 3 different subtypes if we care to go about that, go to either A fibers or C fibers. Those are in the nerve, the specific type of fibers transmitting in that nerve. Then it goes to the dorsal horn spinal cord. To make things a little bit more complicated, the A delta fibers and the C fibers transmit their signals to T cells, which are transmission cells, to further send the message along. So the T cells are going to be important for how we block the pain later. And that's in the dorsal horn of the spinal cord. The T cells are then going to send the signals to the specific tracts, but it's also going to send the pain signals a spinal level or 2 above and below, a few segments above and below the injury. So if I do have that hand hitting, my primary pain can be on C7, but it's also going to send its signals up to C6, C5, and down to C8 and T1 as well. So there is a little bit of a spread of the message, and that's going to further explain some of our referred pain. Why, if my hand hurts, why does it hurt in my armpit? Well, because it's referred pain to the T1 area. So that's important to understand. So then we're in the spinal cord, we're on the right tract. Again, lobes of the brain, tracts in the spinal cord, it's just the specific area. The specific area for pain signals is spinal thalamic tract. It's going to ascend the spinal thalamic tract and enter the thalamus. The thalamus is then going to send its signal out to all of the important areas of the brain it needs to, send somatosensory cortex, hypothalamus, and limbic system. If you're a big brain guy or a girl, then that's where it is. And then all those connections then result in the perception of pain. Whew. So let's go back to where I thought we were simple here. So again, broadly speaking, receptor. Pain speaking, the receptors are called what?
Nociceptors.
Nociceptors. Good. Nociceptors then send their signals to a nerve. But with these pain signals, there's 2 different nerve fiber types. What are they?
A delta and C.
Good. Good. So A delta and C. Then it goes to the dorsal horn of the nerve root. But what happens in there is that it just doesn't hang out. It sends a signal to somebody that's going to help transmit our message along. Those are called what?
Tracks.
Before the track, there's one other step.
T
Cells?
T cells, transmission cells. Yep. So that's what happens there. And then it's going to go to the tract. Which tract specifically?
ascending.
The ascending tract, and I had a special name for the pain and temperature. The nociceptor pain and temperature tract is what? Spinothalamic. Great. And then it's going to go up to the brain via the thalamus first, and then to all the other important areas of the brain. I don't get into too much of the brain. And then it's going to go back to the descending tract to cause some sort of reaction, whatever the wise reaction at the time might be. Drop the rock, whatever it might be.
Sorry, did you say after the T cells is the spinal thalamic?
Yep.
Okay.
Yep. Lindsay's got her hand raised. Go ahead, Lindsay. Got another poll for you guys while Lindsay figures out if she's going to ask a question or not. Everybody's afraid to answer now.
Josh, can I go over that one more time?
Yep.
I just want to make sure my notes are kind of okay. They're a little sloppy over here.
Yep.
The receptor is the nociceptor, the pain receptor. Then it goes to the nerve, which is the fibers A delta and C to the dorsal horn nerve root,
Yep.
to the T cell, to the spinal thalamic tract,
Yep.
to the brain, to the descending tract.
Great.
Then you get a reaction.
So whatever the reaction the brain thinks is wise at the time. Yep.
Okay.
Yep. Lindsay, I'm not sure how. So Lindsay's having trouble with her microphone. I have a little microphone icon at the bottom of the screen. I had heard you earlier, didn't I?
Can she type her question?
Lori, let's go back to your list while she figures out how to type it out. So the one thing in your list that you didn't highlight was how the pain signal also gets transferred a few spinal segments above and below, and that's going to help. That's going to explain our referred pain a little bit more.
Where would that go?
Right after the T cells accept the message, the T cells transmit that message above and below, and then also to the spinal thalamic tract is just ascending. Descending, there's a whole nother list of tracks that I don't want to get into today. I think it's an important concept because when you get to neuro, you're going to be looking at these tracks an awful lot. But there's a whole bunch of ascending tracks because we have proprioception, where's my hand in space kind of messaging that needs to go from our muscles into the brain and then up. And there's pain. Any sensation has basically its own tract. So those are all our ascending. And the names of them are basically the start and end points. So it starts in the spine and then it ends in the thalamus. So that's how the spinal thalamic tract is named. And then our descending tract helps figure out where's the message going to. So it gets really complicated quick. That I think for this class, it's important to understand that tracts are just the lobes of we have lobes of the brain, we have tracts in the spinal cord. Their responsibilities are very similar. You have specific responsibilities, you just do this. And then when you get into neuro, I believe in your fourth semester, I think that's PTA 4, you'll dive into tracks a little bit deeper. So is that enough for you, Lindsay? All right, perfect. All right, does anybody else have any questions?
Josh, one quick one.
Yeah.
I hope it's quick. Does the
Your question might be quick. My answer will not be.
when it ascends back via the spinal thalamic tract,
Yep.
is that separate from the referral pattern, segments above, segments below?
Yep.
Okay.
That's
Thank you.
my understanding of it, although neuro was one of the classes, probably my second worst grade ever was in my neuroanatomy course. So I might have imperfect understanding of it, but I think for our class, we don't need to have perfect understanding of it. I believe what happens, and this is the diagram I've tried to wrap my head around, the T cells send the signal up and down, as well as to the spinal thalamic tract. That's my understanding of it.
Okay, thank you.
Yep. All right. Any other questions? I know this is a lot. Go ahead, Brandon.
So what was the descending track called?
It depends on what the purpose is.
So after the signal takes the ascending and then reaches the brain and then comes back.
Yep. So here, let me. You can thank Brandon for going down this route. Let's share something else. So here is a list of our descending tracks. So again, they're basically named for the areas of anatomy. I'm sorry, these are both ascending and descending. So vestibulospinal. So again, where does it start and where does it end? Corticospinal controls voluntary skilled motor activities. So what we're talking about here is probably more corticospinal tract, that voluntary removal and pulling back and protecting our arm. We have reticulospinal, rubospinal, vestibulospinal, tectospinal. Again, these are all different areas of the brain, and then spinal where it goes to. So it can a different tract is going to control postural movements from visual stimulus, inhibition of flexor to promote extensor activity, promotion of flexor, inhibitory of extensor. So you asked for it.
So the only ascending tract is that spinothalamic tract?
No, there's other tracks. So pain and temperature, crude touch is actually the ventral spinal thalamic. Dorsal columns control proprioception and vibration. Position of joints and muscles are spinocerebellar. So yeah, there are other tracks that you could dive into, and at some point you might. But I don't want to overwhelm us right now. That's just to say, if I was talking about vision today, I'd only be talking about which lobe of the brain.
Occipital.
Occipital, that's it. So, and then so Brandon's question is, hey, is the occipital the only lobe of the brain? No, we also have parietal, we also have temporal, we also, temporal is going to have a lot to do with hearing, frontal is going to. So Brandon's question is, hey, is spinal thalamic tract the only tract? No, there's a bunch of others.
So it just depends on the kind of like pain and sensation?
The type of sensation, yes. Touch,
Okay,
vibration, proprioception, they all have different avenues they need to go on, yes. And then the descending is where in the brain does it originate, and then where does it go? Well, the spine, and then it's going to, what is the movement it's going to control? All right. All right. Any other questions before we layer onto this? Does
No,
everybody
but did
feel
I
like,
fix it? Can you hear me now?
hey, look at this. We can hear Lindsay now.
fixed it. Okay.
All right. I'm going to mute you now. All right. Uh, does does everybody feel like I know some of the details we're gonna have to go along, but is everybody understanding the broad picture of where we go from reception of pain to the brain, and then we know something else is going to happen because of it? Everybody gets that? All right. Let's keep going a little bit. So, abnormal load, abnormal structure, or microtrauma causes an injury sensed by nociceptors. Nociceptors send signals to the specific nerve fiber type, A, delta, or C. Then they send signals to their T cells, transmits above and below, and also into the spinal thalamic tract. The spinal thalamic tract sends a signal to the thalamus. Thalamus sends the information to different important areas of the brain. I'm keeping that a little bit, I'm not diving into that. The brain processes the information and creates some sort of plan to happen, and it sends a descending messaging for a reaction to one, withdraw from the stimulus, so drop the hot rock, and also to activate that muscle guarding. The problem with the muscle guarding, that additional dysfunction, the muscle guarding is going to compress the micro blood vessels, and that's going to lead to ischemia, lack of blood flow. That ischemia is now a new source of pain. Because if we have lack of blood flow, I can't clear the metabolic waste in the area. And that's also going to sensitize more nociceptors. If we sensitize more nociceptors, we're going to get more pain. That's going to create a bigger muscle guarding contraction. What also is going to happen, the healing components are going to be sent down and the edema is going to accumulate, further complicating that waste removal issue. And the edema assigns heat, arrhythmia, pain, loss of function. And then more pain is sent to the brain. So this is a feed-forward cycle. We have positive feedback loops and negative feedback loops. A negative feedback loop, the easy example I have is your house thermostats. So your house thermostat measures how warm the room is. If it's too cold, it's going to sense it, send signal to your heating source of your house. It's going to kick on, the heat's going to raise, the thermostat's going to say, okay, now we're at this temperature, you shut off. So that's negative, right? So that's the negative feedback loop. The loop is stopping itself. If something were to go wrong in your heating system, the thermostat senses it's 70 degrees. It tells the heating source of your house to increase the heat production. The heat production goes to 72 degrees. The thermostat says, yes, that's good. Keep heating the house. Goes to 74. Good. That's good. So that's the feed forward cycle until it gets way too hot. This feed forward cycle or positive feedback loop is what's happening with our pain. So we have nociceptors. We understand the path of the nociceptors to the brain. The descending message is one, withdrawal from the stimulus that caused the pain. Secondary is muscle guarding to protect against further damage. That muscle guarding creates ischemia. Ischemia has accumulation of waste products, which causes more pain. More pain is sent to the brain, which creates more muscle contraction because the body's trying to protect itself even more. That additional protection is causing more complication of removal of waste products, more ischemia, less transfer of components, and there's our feed forward cycle. So pain, muscle guarding causes ischemia, which causes problems, more pain. So that's our pain cycle, which is a positive feedback loop or a feed forward cycle. And it's our job to interrupt that cycle. So for our visual learners, here's what we've got. And so we've got, make this bigger now. Uh-oh. It's a little bit too big. All right. So we start with our abnormal event, abnormal load, abnormal structure, or micro trauma. That creates an injury that's going to stimulate the nociceptor. Nociceptor is going to send its signals to the A, delta, and C nerve fibers. Those nerve fibers are going to send a signal to the dorsal horn in the spinal cord, and it's going to send a signal to the T cells specifically. The T cells, I didn't add it, is going to send its signals to the segments above and below, and also into the spinal cord via the spinal thalamic tract. Spinal thalamic tract is going to send a signal to the thalamus, and then the rest of the parts of the brain. And then we're going to have a descending spinal cord message that's going to create some muscle guarding. Muscle guarding creates ischemia, which causes the metabolic waste not to be cleared, also sensitizes more nociceptors. Edema is going to accumulate, furthering the problem, and then those nociceptors are going to relay that message to the A delta and C nerve fibers, then the T cells, spinal cord, brain, create more muscle guarding, more ischemia. So there it is visually. Does that help everybody's understanding of what's happening here? If I've completely lost somebody, can you either raise your hand or unmute yourself? It's okay if you don't have every single detail memorized yet, but does everybody understand the concepts of this and some of the details? Or does anybody feel completely lost? Lindsay has her emotional support dog. She's sensing the brain cells melting of too much information overload, and she comes over to give a little comfort. That's so nice. All right. I'll tell you what. I think that was a whole lot. I think it's time for about a 7-minute break. And I want to go into some pain management stuff, and then we'll play around with some ice as well. So why don't we take a 7-minute break? We'll come back at 10:30. Okay. All right. I'll see you guys in 7 minutes or so. 10:30. All right, I am back. I added a poll. Once everybody answers the poll, I'll know you guys are back at your respective stations there. I'll be right back. I got to check on my ice. Give me 1 second. All right. It looks like mostly everybody's back. Yeah, the tracks of the spinal cord is the number one answer for what confused me most. And um, yeah, me too. Me too. When I was first learning neuroanatomy, um, it completely threw me for a loop. I think the big things to think about is it's the tracks in the spinal cord are just like tracks in the brain. Tracks in the brain, lobes of the brain. They just have their own responsibilities, and all it is a highway for messaging. If you want to look at, let's see, and I think that's all you really need to know for this class. Different tracks control different messages, and the spinal thalamic tract is what we're going to talk about with pain. But if you want to dive a little bit deeper on it, oh, this froze. My web browser just froze, so if I get kicked out, I'll be back in just a minute. Yeah, this is not going well. All right, I'm gonna have to close my web browser down and come back in. I'll be back in just a minute. All right, quick audio check. Matt, give me a thumbs up if you can hear me. All right, great. So yeah, spinal tracks are confusing. I think for this class, all you really need to know is the that tracks are analogous to different lobes of the brain. So if you wanted a visual of it, here's a cross section of the spinal cord. Now, only one half of this is colored in. So this is on both sides. So this would be the right side of the body. This would be the left side of the body. And so the dorsal columns tracks, ascending tracks would be here. Spinal thalamic tract we're talking about is this one here. We have our lateral spinal thalamic over here. So that's what it looks like. And obviously we're looking kind of at a top-down view of this. But just remember that we cut the cord in half to look at this. It's just one big string going up to the brain. So I hope that visually helps a little bit. And it's just different telephone wires. That's all it is. So I hope that helps a little bit. So let's get into a little bit more about pain management and how we can help this. Now, I will say be careful when looking at pain studies because pain studies, their research methods it can be suspect at times. Um, so sometimes they give someone pain, so they inject a painful inject something that they know is going to stimulate those pain receptors. But there's always biases with that. So if you ever just come across a pain study of, oh, we injected this person with this painful stimulus and then did this treatment for it, there's a lot of biases with that. So just read it all with a big grain of salt. So um, emotional messaging, descending messaging can significantly influence the severity of that perception of pain. The psychological factors like past experience, attention, and emotion all have great impacts to it. And I know I've seen it with my patient where I'm about to palpate something, and it doesn't matter how light I'm about to palpate, they're jumping off of the table before I'm even touching them because they're perceiving pain, and I'm not even touching them yet. Trish, do you ever get that? I know we're seeing people for different reasons, but do you ever see that in your practice?
Yes. And typically I have a patient laying on the table in some position, and the first time that I palpate, they're very, very guarded.
Yeah.
And then it will slowly dissipate as they learn to trust my touch and all of those things. But yes, absolutely, especially
Yeah,
if
and
they're
then
in acute pain.
absolutely. And you're not doing anything to cause pain. You're being as cautious as possible, but yet
Right.
their experience and emotion of someone has hurt me in the past. The last person I saw went too hard. Their emotion of I don't want to be in pain is all influencing that. And then they're learning to trust you, and then now their past experience is now updated to whatever the new experience is. So
Right.
it is so important to understand that. And we're going to touch on endogenous opiates again because they help for a descending control mechanism. So there's a few different types that we've talked about. Enkephalines have a short half-life. That means they quickly remove from the body. They're triggered by a non-painful stimulus. So what happens here is they block the A delta and C fibers transmission of the message to the T cells. So if we can stimulate those enkephalins, then we're going to block the T cells from doing their job. If we block the T cells from doing their job right here, so if we block that, the pain isn't going to get transmitted to the spinal cord and then to the brain, and we're going to be preventing this muscle guarding because the signal to the brain is interrupted. So that's one way that we can really use these for our benefit. Endorphins have about a 4-hour half-life, and they're triggered by intense pain while they're already experiencing pain. But intense exercise, acupuncture, laughter, meditation, relaxation techniques, all of those are going to inhibit the pain signal and decrease the quantity of chemical irritants in the system. And then we could also have serotonin and dopamine. They're also endogenous opiates, but they aren't really well understood. But they do exist and they are important. We just don't know exactly the mechanisms to do it. So when our patients are experiencing a lot of pain, then we can do things to stimulate the non-painful stimulus is going to trigger the enkephalines, and then that's going to limit the T cells from transmitting the message. Big picture, we can talk to our patient about the benefits of intense exercise. We could refer them to acupuncture. You could be as funny as me and make them laugh all the time, or we can look at meditation relaxation for triggering these endorphins release. And that's more of a lifestyle thing than it is a, hey, come on in here, I'll give you some yucks, and then we'll walk out of there. So we're going to look at the pain management. So the gate control theories. So we are going to talk about this an awful lot. So broadly, it's a mechanism to override the pain signal. So anybody ever, what happens after I hit my hand with the hammer? What do I do next? Shake it, right? Who's ever done that? Right? You hit your hand on something and immediately shake it. All right, so that's not something we thought about. Like we didn't think like, geez, I wonder if shaking my hand would be a great idea right now. No, we automatically do it. Why do we do it? Well, that is going to try to block the transmission of the pain signal. So we're adding a non-painful stimulus, shaking of our hand, and what that's trying to do is block the transmission of the pain signals with enkephalines at the T cell level. So broadly speaking, we can use non-painful stimulus to override the painful stimulus. So that is the gate being closed. That non-painful stimulus gate is open. I'm sorry, if we don't have that, the gate is open. Once we add that, it is closed. And if anybody's ever had pain, um, uh, we've all had pain to some degree, and there's pain that we can kind of walk around on. Like I sprained my ankle a few weeks ago, and nowadays it's gotten a lot better. I can walk around. I can do jujitsu and it's okay. But when I go to bed, it starts hurting. Why is it when I'm walking around on it, I'm okay, but then when I go to bed, I can feel it more? Few different mechanisms for this.
Because you stopped moving it.
And what is the
other
moving
signals?
doing? The moving is creating the other non-painful signals. So right, So I can walk around on it. As long as I'm not torquing in that angle that hurts, that inversion ankle sprain, then I'm creating non-painful stimulus. Yeah, absolutely. What are some other reasons that would explain that? Cassandra, what do you got?
Could it also be that there's less distraction, like you're more focused on it?
Absolutely. Attention and emotion, right? So when I'm talking to you guys, I am emotionally invested in what we're talking about. My attention is on you guys. My attention is, am I teaching this right? Are they getting it right? My mind is so focused on this that, yeah, the ankle pain doesn't exist because my brain is so occupied with something else. So again, that goes back to the modulators of pain include attention to it, attention to other things. So when we have somebody who's in bad pain and all they can do is sit on the couch and they can't move because of it, guess what they're doing? They're living completely in that pain. There is no emotional escape from it because there's no cognitive escape from it either. So yeah, great job identifying that, Cassandra. So you two are Trish and Cassandra, you're exactly right. I'm closing the gate with movement and stimulus that's non-painful, but also psychologically and emotionally, I'm adding some things that help decrease my severity of pain perception as well. So great job with that. So let's dive into the gate theory a little bit more. So my nociceptive stimulus is transmitted to the spine in small diameter nerve fibers, A delta and C fibers, A delta myelinated a little bit faster than C fibers unmyelinated. And those tell the cells the message. Non-painful stimulus, touch, pressure, vibration, are transmitted starting in the receptors. Then they send signals to A beta nerve fibers. These A beta nerve fibers are larger in diameter and myelinated, so they are big and fast. So they are bigger and faster than even the A delta fibers. They send their signals to inhibitory interneurons in the spinal cord, which reduce the T cell firing, and that's how we're going to close the gate. So again, more broadly, non-painful stimulus is going to override painful stimulus. How does that work? Well, the non-painful stimulus is going to activate the bigger and faster A beta fibers, and they're going to go to interneurons that block the T cell firing. So the gate is at the T cell. We are not allowing those T cells to fire.
So Josh,
Yep.
the A delta fibers are used with painful stimulus, and the A beta fibers are used with non-painful stimulus, or no?
Yeah. Yep. And I remember it this way: A beta is bigger, B bigger. So
Okay.
bigger and faster. Yep.
Thank you.
So now in the spinal cord, the non-painful stimulus is transmitted to the brain because of that faster nerve conduction velocity. Now, some of it depends on the intensity of the non-painful versus painful stimulus. I think if you chopped my foot off, I wouldn't be able to just shake my leg and say, no, I'm good. Like, the intensity of pain has to match that as well. So that gets to be a little complicated, but I think overall, I think it does make sense. So the non-painful stimulus is going to send signals and block the transmission of that painful stimulus. So when we are treating pain, we typically don't focus on pain only. We look at pain as the result of some sort of other problem. So I want to manage pain. I'm not treating pain. And that's the concept of rehab that sometimes can get frustrated. So the patient comes in complaining of shoulder pain. And instead of only saying, well, let me make you feel better, I'm cranking on their range of motion or making them lift some weights that are challenging for them to lift, in order to address either the abnormal load that they experienced, the abnormal structure that they have, or educate on the micro traumas that we can fix. So I'm trying to fix those things which cause the pain, but the patient's focus is on the pain and not the things that led up to it. So I'm trying to manage the pain, not treating it. We treat the environment that created the pain. So the frequent things that contribute to pain: poor posture, poor body mechanics, decreased flexibility and range of motion, overall decline of fitness are all of the things we want to treat. So the forward head, protracted shoulders that causes neck and shoulder pain. I guarantee you guys have way more neck and shoulder pain. Maybe you've had a little bit of a break from it, but can you guys think back to last semester when you were, in labs, learning all the time, classes all the time, studying all the time, where you had all of that neck pain? And then you had 4 weeks off, maybe have a little bit less of it, but now that you're in class for the last 3 hours almost, 2.5 hours, now, I mean, I've got a little bit of neck and shoulder pain right now. How about you guys? Right? So that's that poor posture causing the pain. So yeah, do we want to put some hot packs on our shoulders, or should we fix our mechanics where we're in a better posture as we're on these video conferences? So I'm going to try to advance the slide. Do you guys see that circle picture again? I can't see you, so was that a no?
No.
Yeah, that was
Nope.
All right, well, I spent a lot of time. How about now?
There it is.
And do you see the stimulate A beta fibers with massage, cold, and heat as well?
Yes.
All right, good. So here's our pain cycle. So I spent a ton of time on the animation of this slide, and now that it's not working, that was a handful of hours wasted, but oh well. So here's our normal pain cycle in the orange, where our physical agents and modalities can interrupt the pain cycle. First, we can stimulate the A beta fibers. We can do that with massage. We can do that with heat and cold. We can do that with e-stim. There's a handful of other techniques that we can do that will close the gate at the T cells, so then they don't continue their message along. Do you guys see where it says massage and biofeedback near muscle guarding now?
Yes.
Yes.
Hey, all right, good. So if we can't do that, or maybe in addition to that, if the patient already has pain and we need to address the muscle guarding, we can do that with different massage techniques. Trigger point is the first one I'm thinking of. Trish, do you have any other techniques that are really good for addressing that muscle guarding? I'm
It
sure you have a
depends.
lot.
Yeah, I mean, it depends how long they've had the pain. I mean, they can just,
Yeah.
I find a lot of it is client education, where that pain is coming from, explaining to them. Like they get confused. Why are you working there? That's not, that hurt,
Right.
but that's so, that's a big window, I guess, a big
Yeah.
answer.
Yeah. No, I mean, that's the answer I was expecting. Yeah, there's a excuse me, a whole range of techniques that we could use. So I clump massage, but to someone like Trish, I'm sure it's almost insulting to like clump all of massage in a category. Just like I get insulted when physical therapy gets clumped into a category. Anyway, we could also have biofeedback. So if we put this little biofeedback machine, that we can put this on the muscle belly or the contraction point for the patient, and they can visually see on a little display how that muscle is contracting. We can address the ischemia with some of our heating. Do you guys see that arrow pop up?
Yes.
All right, good. So we can address the ischemia with heat. So heat's going to cause vasodilation. So the ischemia is contracting those blood vessels and squishing them. Well, if we add heating techniques, that's going to dilate them even more. So that would be helpful. Clearing of metabolic waste, we can use ultrasounds and lasers to try to increase the cell permeability to allow those waste products more free flow into the back into the bloodstream. We can address the edema with cold techniques and some different eSIMs as well. So all of our modalities can hit different points of this pain cycle depending on what we're seeing. Again, indications and what the patient's benefit was. So if the patient thinks, "Oh, I would love a massage," okay, well, I'm going to do a massage, but it's probably not going. If I'm concerned mostly about this muscle guarding, I'm going to use these couple of techniques and not the light type that are better for edema. Because if I don't see edema, well, that massage, while it might be beneficial because we're stimulating the T cells production, well, I'm also not getting to this muscle guarding problem. So this is part of that decision making process, and why we need to understand this pain cycle so significantly is because the application of our physical modalities depend on what do we want to attack in this pain cycle. Does that make sense? Does anybody have any questions with that?
Josh, can you go over the ischemia again and the heat? I had a phone call coming in and I
Okay.
missed it.
So, that muscle guarding compresses all of the blood vessels. That compression of blood vessels decreases blood supply to the working areas. And then the big problem with that is it doesn't clear those metabolic wastes. Lactic acid is the biggest one I can think of. Um, So if that's happening chronically, if we put heat on that muscle or the area that's constricted, then that's going to dilate the blood vessels, allow more blood flow in. So instead of getting mechanically squished, we're going to thermally dilate those blood vessels, and that's going to help increase blood flow.
Okay,
And we'll get into that later too. But yeah, that's how it interrupts in the pain cycle.
awesome. Thank you.
No problem. What other questions do we have? All right. Is anybody confused about anything that we went over today? I mean, we went over a lot. Broadly speaking, pain leads to muscle guarding. Muscle guarding leads to more dysfunction, which leads to more pain. To expand on that, we need to know the different fiber types, what happens at the T cells, and we can interrupt that by stimulating non-painful stimulus, uh, causing A beta fibers to interrupt the T cell signal. Um, so if we don't do that, the T cell send signals above and below, which helps explain some of the referral pain. And it also sends up to the brain via the spinal thalamic tract. The brain processes it and sends some sort of descending action, which is the muscle guarding technique, the muscle guarding that happens. That muscle guarding causes a problem because then it causes the clamping of blood vessels, which causes ischemia. That ischemia causes lack of clearance of those metabolic wastes that are happening, which causes more pain. Edema is going to cause more pain, stimulate more nociceptors, and then that cycle continues on and on. So um, that was in summary what we've talked about for the last 2.5 hours. Um, I know everybody has to digest this more, but does everybody have an overall sense of, okay, I get most of it, at least the broad pieces of it?
I get most of it, but I do have one question.
Yep.
The closed gate is for the non-painful stimulus?
Yep. Yeah.
Okay.
So if we go, if the gate, the gate is the at the T cells. So if the gate is open, the T cells can send its signals wherever it wants,
Go up or down? Okay, can go up
up
or
or
down.
down, and then up to the spinal, up to the brain as well.
And if the A beta cell fibers come in, then it can close that.
It
Okay.
closes the gate. It kicks the gate closed, and now that signal can't go.
Okay.
Horse can't leave that barn. The gate's closed.
There's a lot of information.
Yep, there is. There is. All right. Anybody else with some big problems? All right. Well, what I'd like to finish off our day, and we'll only do this for a little bit, is I'd like to work on our ice massage, because with ice massage, where in the pain cycle are we, where would cold be? Try to think in your brain instead of your notes, but where would ice massage impact this pain cycle?
Like with inflammation?
Absolutely. So, if we do see signs of edema and inflammation, then we can put ice on it, and that's going to decrease the inflammatory cycle. Yes, absolutely. Where else?
Yeah, when the T cells get like transmitted.
Yeah, so we can, so it's non-painful stimulus that we can activate the A beta nerve fibers that's going to block the T cells from sending a signal. Good. So, I've got to go grab my ice. I'm sure you guys are the same. So go grab your ice and towels, and we'll try to experience some of this ice massage stuff. Okay, I'll be right back. Hi, baby girl. Hi, baby.
Can we see her?
You can't talk like that and then not show pictures.
I took my headphones off, so that was, should never do that. But I've got my ice massage live popsicle. So everybody else has that. I also have a big towel that I'll be showing this. So, you know, ice massage is one of the techniques that we can use to help decrease inflammation. We can also interrupt the pain cycle that we were just talking about. We're going to dive into this way more in like 2 weeks. But I just want to quickly go over it. So ice massage is an intense cold application. We can use it for small areas, so either really small areas that we don't need to put cold on the entire elbow, but maybe just that lateral epicondyle. And it also helps with trigger points too. So the time that it takes for what we want. So when we learn cold formally, we're going to learn that the stages to get that we want to go through with our cold applications is C-band. First is cold, then it's burning, then it's aching, and then it's numb. And we want to get to numb if we're going to put cooling effectively. Again, we'll learn all of this now. I just wanted to get some hands-on stuff and see where some of our modalities can interrupt that pain cycle. So it's going to take about 5 to 10 minutes until that numbness starts to occur, and the burning and aching should only last about 2 minutes. So again, small areas, maybe a bursa, trigger point, small muscle belly, 10 centimeter to 15 centimeter area. So I've got my popsicle ice. I told you guys to grab Dixie cups and fill them with water, freeze some water in it. If you do have that, all you do, if it's a paper Dixie cup, the reason why it works really well is because you just tear the top, you know, half an inch off, and then you've got the paper that doesn't make your hand cold, and then you get to use the ice. If you don't have something like that, grabbing onto a cloth. So if I didn't have my little handle, I would have to hold the ice itself. I would just have a cloth around that. So what I want to do just for everybody is let's just get lateral epicondyle. Let's see if I can get this to work. So let's just get lateral epicondyle of it. And I didn't put this in early enough in my in the day to freeze enough, so I'm leaking all over the place. But you know, when we're doing this with our patient, we are going to get them wet. So you want towels everywhere, and just choose a small area and work it in. And you'll feel that cold right away. Pretty quickly, you're going to get into the burning and aching. And if you wanted to, so I'm not doing it right now, but I could add more pressure as I do this ice massage. What is that more pressure doing in the pain cycle?
Josh, I think your video is off.
It's off?
No,
I
it's
can't
on.
see you.
No, it's on.
Oh. You can see him? Huh.
Can see you too.
Yeah. All right, so everybody just keep going at it. We're going to spend 5 or 10 minutes. This will be the last thing we do today, but I want to experience that cold, burning, aching numbness, and hopefully getting to that numbness. I'm definitely at the cold point now. How's everybody else feeling? Cassandra, what do you got?
The pressure, was that creating like non-painful stimulus?
Absolutely, yeah. Thanks for answering the question. I forgot. Lindsay interrupted me, and I forgot that I asked that question. Yes. So, one thing we could do is we could just keep it very superficial, and that's still doing the thermal aspect that we want. But if I add a little bit more pressure to it, then I can add more of that non-painful stimulus, stimulating the A beta fibers, interrupting the T cells, and interrupting the pain cycle. I'm starting to get to some of the burning part. Anybody else feel that burning part yet?
Yep.
So what do you think has to happen? So first we educate our patients about C-band and the stages that they're going to feel. What do you think they're going to start feeling or talking about right now?
Do you have to go anymore? Do you have to
Like,
keep
yeah,
going?
what are you doing? This hurt. Like, I don't want this. And you're going to explain to them, yes, this should only last, and this ice massage is going to be about 2 minutes. Once we get there, you're going to experience an ache. That burn is going to turn to an ache. And once we get after the ache, it's going to be numb. And that's how we know we're going to be cooling those tissues as much as we need to. So keep at it. We've got a few more minutes to go. Anybody dripping all over the place and making a mess? Anybody didn't get enough towels?
This was the best thing for when I had shoulder surgery. This was better than an ice pack.
Oh, yeah?
Yeah, the ice pack was great for, you could keep it on for a while, but if I wanted like immediate, right now, I want to take care of this throbbing pain, this was pretty awesome.
So we are going to look at ice pack. I actually have one I can show you. But why do you think that is?
Why do I think the difference?
Yeah, why do you think you experienced more relief with this than you did with just the cold pack?
Because I could isolate an area that I knew was more painful for me. The ice pack was nice overall where it kind of spread out.
Yep.
But the Dixie cup actually just sent to an isolated area. If I wanted just if I wanted just the front of my shoulder, like
Yep.
I could put right here. If I wanted my bicep groove, I could put it right there. If I wanted my tricep, I could put it in the back. If I needed to sit, why I was asking about pressure and positioning was because when I was using this, I would put this block right against my shoulder blade, right against
Yep.
my scapula to try and loosen it up a little bit. And I felt more pressure was nice, and the ice pack would not get that.
And why do you think more pressure was nice? There's two reasons for it. One we haven't talked about, one we have.
More pressure for that was I could control the amount of pressure.
Okay, but
like
why did that help you with pain more? Dakota, what do you think? Why did she like that pressure more?
I'm not too sure. Maybe it distracts from the other type of pain, or
You're exactly right. And Justin, can you talk about why that is? Why did it distract from the other pain?
is it like
Justin.
shaking?
It's the same thing as shaking, absolutely. And what's the science behind it? What are the complicated terms that we want to use so that pressure,
The beta.
yeah, go ahead, go to say it again.
The beta fibers are, yeah.
That's exactly it. We're stimulating the A beta fibers, which is then interrupting the signaling where? Who else can say where is it interrupting?
The T cells.
It's interrupting at the T cells, and that's interrupting the pain cycle. Yes, absolutely. Yep. There's also something about, so these cold applications, we need contact for it. So one of the reasons why ice massage is good is because we are in direct contact. The ice packs, we're laying them on our patient. So if we don't strap it in, so if Lori's experiencing pain in the front of her shoulder, if we just lay an ice pack on top of the shoulder, it might not make enough contact with the anterior part of the shoulder. It's kind of just draped and not making direct contact. And so then it's ineffective at cooling the area that we want. So we'll talk about that later. Have you guys reached that numbness level? I have.
Yep.
Yeah.
Yeah, good. So then we, as a clinician, once we achieve that numbness level, we can decide, do we want to keep going for a few extra minutes or do we want to stop? I'm going to stop because that's numb enough.
Josh, isn't it true that like laying an ice pack too, you're always going to have a layer against the skin in between?
Yep.
So that
Yep.
is not
Yep.
just ice on the skin, so it's a different thing. Different.
Absolutely, yes. The intensity of it is going to be a lot less. Yeah, and we'll get into that in a few weeks. But, I just wanted to kind of highlight with this ice massage example, one, I thought it was something that we could all do at home. Two, I wanted to just highlight how we can interrupt those pain cycles with our modalities. And sometimes it's a few different ways we do it. So, yeah, it was just a little hands-on activity that I thought we could do. We will dive into thermal modalities way more later, but just something for us for today. So, do you guys, that's it for what I want to go over today. Do you guys have any questions?
A quick question about the ice massage.
Yeah.
How much skin redness is to be expected? Like my arm got very red.
So there is going to be some redness. And Mel, I know you have more fair skin, so my daughter's the same way, and so your skin is going to have a more exaggerated response than someone who has a darker complexion. We call that the Lewis-Hunting effect. Well, if it's red and splotchy, and we'll learn about that later, but that is okay. Yep.
So who would not be a good candidate for ice massage? Like, does the contraindication still pertain to like someone like who's pregnant? Can you not do ice massage, or is that just?
Let's see. So I don't have pregnancy as a contraindication. Johanna, you're next, okay? But thermoregulatory problems, some wound healing would be an issue. There's also this crazy thing called cryoglobulinemia. That's an incredibly rare disorder where the blood is going to coagulate and form clots in response to cold. So that's probably something yeah, so you don't want to come across that and say like, let's put some ice on you. Like, no. We don't want to do it over regenerating peripheral nerves. So if someone had a surgery or where they just cut through some of these cutaneous nerves, we don't really want to put ice on that just because it's going to slow the regeneration of it. If someone had Raynaud's disease, that would be a contraindication to using cold. If they had sensory deficits or if they just didn't like it, that would be something. One other precaution is actually high blood pressure, because cold can cause a transient increase in blood pressure just for a little while. So that's another reason last semester everybody said, why do we have to check vitals? Why do we have to learn about this? Because even with high blood pressure, you putting cold on somebody could increase their blood pressure even more for that time being. And if it's already too high, we don't want to do anything that would make it just tip even higher. So yeah, but we'll learn all that in a few weeks. Not today. I think we've learned enough. I don't know if you guys want to keep learning more. I guess I have another half hour. I could fill your heads with information, but I think we've learned enough. Johanna, you had a question. Johanna, I can't hear you. There's a way you gotta.
Sorry, my microphone was off.
Good. You're good.
My question was, is there's any time frame that we need to do the ice massage? Because I noticed Melanie says that she was getting red. I needed to go like for a long time. I don't know if it have to do with the skin color, because I feel the numbness like very, very towards the end.
Yeah, yeah. So we want to get to, and again, these are questions we're going to dive into more on, I think it's week 3 I have it planned for.
Okay.
But that's okay. So we want, when we're doing cold therapy, whatever it might be, ice pack, cold pack, ice massage, anything along those lines, we want to get the patient where they're at the numbness stage. So CBAN, CBAN, cold burning aching numbness, we want to get them to numbness. If we want to go further and maintain that for longer, it depends on the clinical judgment of the patient. Someone like Mel, if her skin is turning that red and splotchy, Lewis Hunting effect, I will probably stop that sooner. But we're going to get into that decision making in a few weeks.
Okay. Because right now, like mine, it's burning, and I'm not even have the eyes on me. I don't know if I rub it, like I feel it burns.
Yep. Yeah, some of those effects can last for a while, and that's okay. When our tissue temperature heats back up, it'll be fine. Yeah.
All right, got it.
All right. Any other questions from anybody? All right, good. So at 12:30 we have pathophysiology. Both Christine and I will be on. And so that's at 12:30. So you guys have about an hour for lunch, and we'll talk about patho. That I will say patho, the synchronous portion today should only last maybe 30 to 40 minutes, and then you have some videos to watch on your own. So you should have some more free time later. But I'll stay on for a little while longer if anybody else has questions. If not, you guys are free to go. Keep your eyes on your email, because as soon as we can go back to campus within whatever regulations that we have to, as soon as it's beneficial to be on campus, I'm going to have us on campus. But if it's not extra beneficial, then I don't. The way it is right now, we've got a lot of hoops to jump through, and if those hoops are good to jump through because we need to, then I absolutely will. Today wasn't that day. I thought we could be just as beneficial in this format than in person, and not jump through those hoops. So keep your eyes on your email. Things might change. Right now, my gut feeling is we'll be online again on Thursday. But if there's a way for us to be on campus, then we'll take that opportunity. But my gut feeling is we'll be online. But just keep your eyes on your email, okay? All right. I will see you guys in about an hour. I'll stay
Thanks,
on for any
Josh.
questions. See you in a little bit.
Thank you.
Thanks, Josh.
Josh, I do have a question.
Yep.
So Tuesdays, so when we are back on campus, if we are, for PTA 2, and then we're synchronous for pathophys, are we gonna have, like, so for me it's like a 45-minute drive back home? Like,
Yep.
so if we're on campus for PTA 2, and then we're gonna have enough time to like get home and get on our computers for 12:30?
Yep.
Okay.
So yes. The short answer is yes. Don't worry about it. We'll explain more during patho. But basically, there's going to be mostly asynchronous lectures you'll be watching. So whether you choose to watch them on your drive home,
Gotcha.
and the sickness days are basically going to be exam days where you're going to be on campus anyway.
Okay.
So yeah, Christine and I and all of you, we're going to work together to make sure that patho is easy for everybody, at least location wise.
Okay.
Yeah. All right. I'll see you in a little bit. Any other questions? Dan, Keith, Trish?
Yeah, I just have a quick
Ashley?
one.
Yeah.
It might be answered in a week or two or whatever. Might be a silly question. You know how, like, when you're generally applying an ice pack, they say don't apply direct contact to the skin. Is that, and obviously with the ice massage we just did apply direct contact.
Yep.
When we go over just like cold packs, are we not applying those directly to the skin?
No, there's going to be a barrier in between. Typically, a thin pillowcase is the barrier. That's to protect the skin integrity, because with ice massage, I'm staring at the skin as I'm doing it. So I can stop the treatment if I see adverse reaction. With an ice pack, it's less intense and longer in duration. So I can walk away with it, but I don't want to walk away if there's any danger to the patient. So that's why it's a safety thing. But yeah, we'll talk about the reasons why we would choose intense cold like an ice massage or an ice bath versus the moderate intensity cold like an ice pack. We'll talk about that.
Okay, thank you.
Yeah, good question though.
All right.
Ashley, see you.
My question is a little like off topic from class and whatnot. It's kind of like a future question. So I've been asked to go on vacation and whatnot, and it's in the summer, but I know we have summer session, and I didn't know if we were completely throughout like the whole summer session 1 and 2, or if we started summer session 2. I didn't know how that like schedule for summer worked, and so they're kind of like nudging me to give them an answer like ASAP, but I wanted to talk to you to like see if you had any answers as to like if like no go if I can't go on vacation, it's not a big deal, you know what I mean? It's vacation. I want to do this.
Yeah.
But I just want to know like how that schedule kind of looks like.
I wish I knew. I don't really know the answer. I wish I did. Tony has a better grasp of that.
Okay.
But some of that is also dictated by your clinical site too. So I would lean towards plan on not going is what I would tell you, but talk to Tony because he has a better handle on it.
Yeah, because like I looked at the summer session and like lands between like both sessions, and I was like, do I risk saying yes and putting out the money for it, or do I just say no and deal with it? So I'll probably just lean towards no and just like avoid the whole